you everyone for joining us. In this session, we're going to discuss social influencers of health and education, often referred to as social determinants of health, and we'll outline how school health services can address these influencers via a multi-tiered system of support. I'm Catherine Cushing. I'm the Program Manager for Quality Research and Evaluation at the School-Based Health Alliance, and I am joined by partners for the Center for Health and Healthcare in Schools and the National Center for School Mental Health. We're going to start off with an overview of school-based health centers and comprehensive school mental health systems, and then we'll pass it over to the Center for Health and Healthcare in Schools to present our joint work around the social influencers of health and education. Some housekeeping things to note. You are muted. This is a webinar, but please use the chat to send in questions to our moderators and presenters. The webinar will be recorded and will be made available. If you require technical assistance during the presentation, please use the chat to message our panelists. And for general inquiries, go ahead and email the Center for Health and Healthcare at Schools at GWU. Great. So a little bit of our agenda overview. As I mentioned, we are going to give an overview of school-based health centers and comprehensive school mental health systems and our joint national quality initiative. We'll introduce the social influencers of health and education, and then we'll talk about assessing SIHE through screening and surveillance and providing multi-tiered interventions to address unmet SIHE needs. But first, we want to get a little sense of who's here. You'll see a poll pop up, and we'd like you to select what role you represent. I'll give you a few minutes to do that. Great. Nisha, can we show the results for that? Okay. Seeing a lot of state folks, community-based folks, some school mental health providers up there too. Wonderful. Okay. And our next poll is want to know where you're currently located. Great. This should be pretty quick, so let's pull the results up for that. Oh, okay. Lots of Northeast, people from the West. Wonderful. Well, thank you all for joining us, especially those of you on the West Coast if this is lunchtime, or those of you who are at other odd hours. Appreciate you being here. Before we dig in, we want to acknowledge that this work is supported by the Health Resources and Service Administration, HRSA's Maternal and Child Health Bureau, through the Collaborative Improvement and Innovation Network on School-Based Health Services grant. Since 1995, the School-Based Health Alliance has supported and advocated for high-quality healthcare in schools for the nation's most vulnerable children. Working at the intersection of healthcare and education, SBHA is recognized as a leader in the field, a source of information on best practices, and a national provider of technical assistance and training to the school-based healthcare field. We contribute to the improvement of child and adolescent health through school-based healthcare by supporting and creating community and school partnerships. One of the most common models of school-based healthcare is school-based health centers. School-based health centers provide the nation's most vulnerable children and youth with access to primary care, behavioral health, oral health, and vision care, where they spend the majority of their time at school. These services are provided by a community health systems or a combination of organizations through an agreement with the school. SBHCs collaborate with school districts, school principals, teachers, school staff, families, and students. And with that, I'll pass it over to my partner, Sean, to give some background on the National Center for School Mental Health and Comprehensive School Mental Health Systems.
Thank you, Catherine, and good afternoon, everyone. My name is Sean Ornstein, and I am a Program and Policy Manager at the National Center for School Mental Health. The National Center for School Mental Health was established in 1995 with funding from the Health Resources and Services Administration Maternal and Child Health Bureau. We are based at the University of Maryland School of Medicine in the Department of Psychiatry. And our mission, as you can see here, is to strengthen policies and programs in school mental health to improve learning and promote success for America's youth. The National Center for School Mental Health is focused on research, training, policy, and practice to advance school mental health at the local, state, national, and federal level. You can find out much more about what we do at schoolmentalhealth.org. Comprehensive school mental health systems represent a full array of supports and services that promote positive school climate, social emotional learning, mental health, and well-being, while simultaneously reducing the prevalence and severity of mental health challenges and mental illness. We always emphasize that school mental health systems are built on a strong foundation of school and district professionals, and that includes administrators and educators, specialized support personnel, all in strategic partnership with students, families, and community partners, including community health and behavioral health partners. And finally, comprehensive school mental health systems assess and address the social and environmental factors that impact health and mental health. The inequitable distribution of health and education resources across communities has created profound disparities in opportunity for young people, fueled by discrimination, racism, and economic segregation. These structural inequities contribute to chronic absenteeism, school failure, substance use, depression, asthma, obesity, and other challenges. Youth who are disconnected from systemic resources are often less healthy and less likely to do well in school than their peers who have social advantages like high quality education in safe and supportive school climates, readily accessible medical, behavioral, and oral health services, and access to nutritious foods. At the intersection of the health and education systems, school-based health services can help us close these gaps. With this in mind, the goals of our National Quality Initiative are to improve quality of care and use of best business practices that promote sustainability among 50% of school-based health centers and comprehensive school mental health systems, to increase the number of and the utilization of school-based health centers and comprehensive school mental health systems by 15%, and to increase state policies and programs that promote quality, sustainability, and growth of school-based health services.
Great. Thanks, Sean. Despite challenges associated with changing these societal and community factors, school-based health centers and comprehensive school mental health systems are well positioned to assess and take actions to help overcome these obstacles to student achievement, social and emotional development, and well-being. With this in mind, the School-Based Health Alliance and National Center for School Mental Health partnered with the Center for Health and Healthcare in Schools to develop 3 briefs as part of our National Quality Initiative work, highlighting opportunities for school-based health centers and comprehensive school mental health systems to address social influencers of health and education. And with that, I will let our partners at the Center for Health and Healthcare in Schools introduce themselves and share more about this work.
Hi, everyone. I'm so pleased to be here with our partners and to share a little bit about our joint work. I am Olga Acosta-Price. I am director of the Center for Health and Healthcare in Schools and an associate professor at the Milken Institute School of Public Health. And I will have Rachel quickly introduce herself.
Hi, everyone. I'm Rachel Sadlin. I'm pleased to be here with you all today. I'm the associate director of Research and Evaluation at the Center for Health and Healthcare in Schools.
Terrific. I'd like to just give you just say a couple words about our center and what we do. So we are a center that aims to advance and support effective school-connected initiatives to improve students' health, educational attainment, and really overall well-being. We're really one of the only TA, technical assistance resource, and translational research centers that are focused on school health and housed in the School of Public Health. And the reason that is worth mentioning is because it influences a lot the way we approach our work and the frameworks and theories that we utilize to advocate for holistic systems of support for children and their families, and really focused on interventions that are at the practice, organizational, and systems levels that we hope will improve outcomes for all youth. Next. So the good news about what our data had shown us before the pandemic through the National Survey of Children's Health is that the conditions in which many children and families live in the US certainly tell us that there's some things that we have done well as part of our kind of public health and behavioral health and education strategies. We know that as reported by a representative sample and published in 2019, 2020, that the majority, 96% of children aged 0 to 17 had received needed health care in the past year, and that over 93% are covered by health insurance. That about 29% of children, but I'm sorry, the downside or some of the conditions in which we have to, that remain causes of concern are that 29% of children, their families report live in neighborhoods that are neglected, that have litter and rundown housing and or vandalism that impact kind of their neighborhoods and circumstances, that 19% of households with children 0 to 17 live below the federal poverty level, and that 15% report somewhat or very often hard to get by on their available family income, and that a little more than 5% of households with children couldn't afford enough to eat sometimes or often, as reported by their parents. So certainly what we knew to be some of the factors that influence young people's lives and their families' lives were not ideal. And there were still many and had been many families that were suffering in the conditions in which they lived and learned. Next. But certainly we have learned by our national reporting and the many ways that we have collected information in the past year and a half as we have lived through a pandemic, is that the needs that existed before this time demonstrate that those needs have only been exacerbated, and particularly for disproportionately have impacted young people and their families who are from marginalized neighborhoods, marginalized communities, and that certain conditions have worsened. Food insecurity, parental unemployment, especially for those who live in service jobs. The digital divide has widened for many families, and just the loss of life that has not, again, that has impacted many, many people across the US, but again, has disproportionately impacted some communities and families more than others. Next. And what we know is that when children go to school, whether in person or remotely, they go to school with these experiences very much present and impacting their ability to learn. Given how pervasive the impact, we know that teachers and educators have been incredibly challenged, and this was so before the pandemic, but again worsened in the last year and a half or so, and have really impeded educators and school staff's ability to both facilitate young people's social and emotional development and address kind of their social needs, while also trying to minimize and mitigate learning loss. And it has really put an incredible burden on those working in and around schools to really try to manage many of those conditions. Next. What we know also is that these stressors have contributed to both and continue to contribute to both health and learning outcomes. So for example, the conditions in which families and children find themselves can be exacerbated by poor indoor air quality in the home, by lack of safe places to play and safe places and safe access to school, and mental and behavioral health problems, including those caused by ACEs. And so these stressors can certainly exacerbate both existing physical and behavioral conditions, and are linked to educational outcomes. In addition, we know that these conditions originate external to the education setting and hinder students' school performance, as evidenced by increases in their chronic absenteeism, lower on-time graduation rates, greater likelihood of school dropout. And next slide. And what we know is that these influences are reciprocal, and that the effect of one's health status and academic performance are very much reciprocal and interconnected. And that interconnectedness continues and has an influence even into later adulthood. What we also appreciate about this framing offered here is that it's all embedded within a particular set of contextual factors that also influence one's access to the quality and the reliability of care, of educational practices, and opportunities that would promote better outcomes. And so they're very much determined by or influenced by these set of contextual factors. Next. So one very brief example of what we mean, which you likely may have had many experiences with, is students living in poor housing conditions. So for those families who have very limited opportunities or have very limited choices in the places where they may live with their children, may be forced to live in places with poor indoor air quality, and that may actually be exacerbated by smoking, by pet dander, by dust mites, by animal droppings, which can aggravate some existing childhood asthma or asthmatic condition. And this condition, we know, is one of the greatest contributors to absenteeism in the United States and subsequent gaps in learning. Next. And so, of course, we do need to appreciate and address any symptoms that present themselves as providers, as social service agencies, as community health and mental health and physical health providers. We want to reduce symptoms anytime that we can. But as given in that example, the symptoms, for example, of potentially exacerbated asthmatic symptoms and the need for emergency care may be some of the symptoms that we've presented, and the underlying problem, or the problem may be that they have triggers that continue to exacerbate that condition. What we want to think about is understanding the root causes of what and where interventions could actually take place. And it requires us to really fully appreciate and understand those environments and the characteristics of the conditions in which people are born and grow, live, learn, work, and age. And this is what is often considered the social determinants of health. And these are the fundamental drivers of health and mental health status and long-term success. And although, for example, we may appreciate that the problem at hand may be that this individual student is absent quite often from school, the underlying cause is really that they are living in an environment or in a housing condition in which their physical illness is exacerbated and makes them unable to fully access and participate in their education. And it's thinking about the ways that we might jointly think to dismantle and address some of those root causes that we hope to continue to forward through these discussions. Next. The CDC offers an understanding, because certainly the social determinants of health, as we've come to understand them in public health, really encompass many, many different factors. And the CDC sort of helps to provide a framing, or at least an organizing way to think about them in these buckets as the kinds of neighborhood and built environmental factors, health and healthcare, social and community contexts, things around about the neighborhoods and about the social cohesion and characteristics of the community, as well as education and economic stability as some of the main key social determinants. And what we know from research is that our medical status, or our morbidity and mortality, our medical care and clinical care really only accounts for about 10 to 15% of our health status or our health outcomes. The social determinants and these environments in which we live, and when those are measured and assessed, actually are much more predictive of our health outcomes than the availability of medical care in and of itself. Next. So we have together really been shaped and thought about an alternate framing, which is rooted in many of the same concepts of social determinants, but acknowledge the role of development in children and youth, and also acknowledge how many of these root causes are factors that are interconnected and shape both domains of functioning, both at the health status as well as educational achievement, and are often really external to the individual and their ability to really move the needle themselves on these kind of structural, organizational, or policy kinds of factors. We also want to very much acknowledge and appreciate that often these influencers of health and education are experienced disproportionately by race and ethnicity, by sexual identity, and by other characteristics that have groups more vulnerable to the impact of these factors, and contribute to both health inequities, to learning disruptions, and to opportunity gaps, which again only continue to widen the kinds of general disparities that we see as part of the lifelong outcomes. And so this term, social influencers of health and education, is I think encompasses much of what we are trying to convey about the fact that we are identifying things that are potentially modifiable, that can be changed, and that can have a great impact on current and future health and education outcomes. Next. Social influencers in and of themselves, as with social determinants, are not inherently negative. They can be both positive, and we don't want to only use sort of a frame in which we are only addressing and thinking about how conditions are negative, but conditions can be, and we certainly should be striving for them to be positive. And what we know to be protective factors, and how we want to understand from the research and from our practice how these factors can be enhanced, can be facilitated, and so that we can measure and demonstrate that they can be disproportionately more available to our communities and populations to outweigh or mitigate what may be some existing risk factors. So factors, again, we don't want to convey that these factors in and of themselves are value laden. We need to understand and appreciate the role they play in influencing both health and education. Next. So we're going to ask if you would take a second and, from your perspective, let us know from your position, from your perspective, can you tell us what are some of the top concerns for students in your community right now. And you can select your top 2 if you would take a moment to do that. So we'll see those results in a moment. Hopefully I can see them. And if not, we'll ask one of our co-presenters. Okay, are those showing up yet? Let's see. Well, there we go. So we have, wow, so almost half of those of you participating today have indicated that trauma and ACEs, so adverse childhood experiences and trauma exposure, are significant in your communities. The next, in housing instability and homelessness, along with food insecurity and poor access to services and supports, which we again know are really critical to maintaining health and to being able to take advantage and participate in our educational experiences. So thank you for that. It's important for us to keep in mind as we're thinking about the role we can play to mitigate these factors. So I will quickly just say that the first brief in this series of 3 briefs that we jointly published is really on understanding the social influences of health and education. And it provides an overview of what we know to be sort of a synthesis of some of the literature and what those influencers are, particularly the common influencers for children and youth, and describes the role of schools, in particular school-based health centers and comprehensive school mental health systems. And from that leverage point, how we can begin to identify and begin to hopefully together mitigate the impact of these influencers. And we start to articulate a call to action and next steps for the field within this first brief. And we are placing the link in the chat. So if you want to start to access any of these briefs at any point, you can access them from that URL. So now I will turn it to Rachel, who will be able to go through and give you an overview of the next 2 briefs. Thank you.
Good afternoon, everyone. Good to see you all. So this next section covers how to dive deeper into this topic in your school or local community through the use of social influencers assessment. We know that schools already collect a vast array of data, some of which tells us about student experiences, maybe at home or in the community, such as health screening data or chronic absenteeism or indicators of their social emotional learning. And an additional area where schools might be able to begin collecting data is around some of these neighborhood, household, and family contexts that students are facing. And so by better understanding social and environmental factors, schools might be able to take action and make data-driven decisions about policy or program changes to best serve the needs of children. And as Olga already described, we're not just focused on the deficit lens of social influencers. This is really an opportunity to identify strengths in the community and assets in our youth, as well as to uncover what some of the unmet needs are and opportunities for improvement. And so we see there as being 2 routes to assessment. The first is through screening, which is defined as the use of a systematic tool or process to identify the strengths and needs of students. And so typically when we think about screening, we think of some sort of validated tool that has cutoff scores or some sort of summing of scores to be able to identify whether or not a child meets a certain risk factor or has a certain number of assets or perhaps developed skills and competencies. So there are some tools, and we'll show you those later, but screening can also take place through the use of existing administrative data. Teams can really rally around some of the data that schools already collect, like I mentioned on the previous slide, looking at attendance records, looking at discipline referrals, looking at other measures that are routinely collected, and then identifying how you look at all of that data together and how to perhaps classify whether some students may require additional services because of their expected level of risk. Another way in which you might have your screening process unfold is to determine whether you want to do universal screening or targeted screening. So that universal screening will be for all students, regardless of whether or not they have any risk status. So if we're talking about a multi-tiered system of supports framework, that sort of tier 1 universal approach. But you may suspect that a particular subgroup needs screening, or sometimes due to some decisions around resources, you may identify that targeted screening is the way to go. And so you may screen a particular subset of students, like a grade level, or perhaps those that meet a certain criteria. So screening is really your first option. And your second is through surveillance. And so surveillance is the systematic collection and reporting of data using surveys and questionnaires to monitor patterns and trends during a moment in time, but also very helpful to see longitudinally what's sort of happening with the population or the subgroup of interest. And so there's a lot of surveys that are done at various levels, national, state, community, county, major metropolitan areas, all the way down to zip codes. So there's a lot of way to drill into surveillance data. You may also use some school-wide surveys and questionnaires that are uniquely administered in your own setting. Some of these may be through more validated and widely used questionnaires available in the field. And then some schools and their community partners elect to take more of a homegrown approach by asking particular questions unique to their context and based on what information they're hoping to collect. Now, a couple of the existing surveys that might begin to uncover some of the environmental influencers in the lives of students include Panorama Education's Distance and Hybrid Learning Survey, which was released about a year ago during COVID-19. Perhaps as we have gone back to in-person learning, not all the questions apply, but there are still great questions about technology access, health and safety concerns, and other related COVID questions. There's also the Casey School Experience Surveys. This is a suite of school climate and student experience questionnaires, and some of the particular modules ask more around the context surrounding the child. So surveillance is a second approach. And so schools may elect to do one or both approaches, but we find them to have some great synergy when used together and when schools have the resources to do so. So screening and surveillance may be done in tandem to sort of get the individual student lens as well as that wide population view. So they can be done hand in hand so you understand who is impacted by certain social and environmental contexts, and then sort of the general or broader extent. It can also be a stepwise approach in which you may look at surveillance data. To what extent in my community does food insecurity impact households? And then if that number appears to be concerning, to think about how do we roll out screening in the school so we know exactly who these children are so that we can pinpoint and direct them to services. So questions to ask yourself and ask your team or ask your coalition before starting with assessing social influencers. The first is to ask yourself which related measurement activities already exist. One example is community health needs assessment reports, which often show a great snapshot of not just the health behaviors and health conditions of a community, but also some of these underlying drivers and socio-demographic factors. You may choose to sort of audit what data points you're already collecting and what your partners are also collecting, so as not to duplicate efforts. So thinking about what do we currently measure and collect, which might help to answer some of the questions we have around unmet social needs. Then to think about what is the scope of measurement activities. Are we wondering about a particular small subgroup of students? Perhaps our students who are receiving free and reduced price meals, or maybe children of immigrant and refugee families, or do we want to broadly know all children in our school community? So thinking about that. And then what are the desired actions and strategies when addressing social influencers? Surveillance activities can begin to help understand what policy and programmatic changes might be required at the local or school level. But if you were to roll out screening, that may help to inform the interventions that you will put in place, perhaps through your school-based health center, your comprehensive school mental health system, or your other partners to help address those individual needs of the child that screen in a particular way. So thinking about what you hope to get out of the assessment activity. The fourth question is, what is feasible? Do you have the personnel, material resources, financial resources, and technology to undertake assessment on the scale in which you're thinking about? And then aside from sort of the organizational and personnel resources, there's also the buy-in factor. Can this be implemented? Can some of these measures be administered? Which can only be done through cooperation and shared buy-in, that this is a priority. And then finally, thinking up through the ethical and regulatory considerations, such as, what will be the process for parental notification, thinking through, when your staff are mandated reporters, when that goes to the appropriate authorities, when confidentiality needs to be maintained, and when it needs to, be breached, as well as the safekeeping of certain records. So talking in depth about what screening options there are and what screening considerations you may want to have discussions around. Again, thinking through whether you have existing measures in place or you'd like to adopt something new. An important point is that many of these screening tools have been developed for parent or guardian proxy report of their child's experience. Typically, and obviously, the child self-report measures are typically for those of adolescent children. So in order to capture the experiences of younger children or more vulnerable populations, it's often the parent, guardian, or caregiver self-reporting. And then this in turn leads to questions of how perceptions may differ between the child and that of the parent or guardian, and whether an adult responding on behalf of the child would necessarily be forthcoming with topics that may be sensitive in nature, because there's a social desirability factor to not disclose issues of unmet basic needs or financial hardship or other vulnerable topics. As I mentioned before, also considering how you'll address issues of mandated reporting and assuring confidentiality. So our second brief provides screening considerations and really focuses on the 5 on the right-hand side, what to consider when administering it, the population, whether there's an associated cost, languages, and the influencers that it assesses. So these are just some of the screening examples that focus particularly on children. And so we provide 8 as examples. And I hope some of these are familiar to you. One thing to note is that there is no particular school-based screening tool at this time. However, many of these can be used in schools, and some of the administration considerations will tell you how and by whom these can be delivered by. And so just to provide 3 quick examples from that set of 11, the rapid assessment for adolescent preventive services, or RAPS, is a very common screening tool. This is a screenshot from our brief, which provides that brief information that this is often administered by a healthcare provider or clinical staff member. You'll see that there is sort of a core questionnaire of 21 items and then some supplemental information. And this one does come at a cost, is available in English and Spanish, covers 3 age ranges, and addresses 3 items: academics, basic needs, and housing instability. Now, some of these screening questionnaires may get into questions of health and mental health status, but for the purpose of this brief and for this presentation, we really focused on those influencers, those true social determinants of health. Here is another, the Prepare assessment tool, which includes 17 questions, plus 4 additional optional questions. This is free, and this is reported by the adult instead of the child. It is in a host of languages, and you'll see it has a number of measures, some of which are quite interesting to uncover, such as parental incarceration history, exposure to domestic violence, whether households have migrant or seasonal farm workers, etc. The third one we'll share briefly is the Pediatric ACEs screening and related life events screener. This one, the ACEs scale is very well known at this point, adverse childhood experiences. And here we show that there's 2 versions, the child version, which is administered by parents and guardians, and the teen version, which can be self-report by adolescents. So a quick question for you all is, what screening tool are you using or have you used with children in your community? So we'll launch this poll, and I'll ask that one of our moderators please share back our findings.
And Rachel, while we're waiting for that, I wonder if you wouldn't mind going to the Q&A, and if you feel ready to answer the question about whether any of the tools are specifically applicable to children with disabilities. Thinking about our research, I couldn't remember if any specifically address that.
That is a great question and an important consideration. I have not uncovered anything on that, but one I'd love to dive into. Please feel free to share your information with us if you'd like to continue the conversation, or if we can pass along anything that we may find. So do we have some results?
I'm happy to share. So the poll shows that, let's see here. The majority, about 36% of the participants, say they don't use a screening tool, and another 26% say they're not sure. Of those of you who have answered that you do use, about 7% use Prepare and RAPS. 20% say other, which I don't know with the poll that we can uncover what that means. But it seems that we really do have this is an area for us to really kind of grow together and really see the opportunities that we might have to implement screening tools together.
Yes, and please share those in the chat if you feel comfortable, those other ones that you are using. And so, as we mentioned, that second option is surveillance. And we've highlighted a selection of 8 great survey systems and GIS mapping systems that are publicly available, that are free, and that are regularly updated. And these are available at different levels: national, state, local, zip code level. The American Community Survey, which is linked to the US Census Bureau, is a great snapshot for your basic socio-demographic information. United Way works with participating states to examine a new measure of financial hardship, which is above that of the federal poverty level, but is still difficult to make ends meet given the cost of living in a particular area. So that's called the ALICE data. And there's more. We already highlighted that National Survey of Children's Health at the beginning of this presentation. We've added the Youth Risk Behavior Survey because it's a popular one and it's one that we like. However, it's mostly focused on health risk behaviors such as adolescent substance abuse and underage drinking, risky sexual behaviors, mental health status, violence, and gets at less of those environmental contexts that children are living in. So just a caveat that it is a great source of data, but may not go as upstream as some of these other data sets. And I just wanted to share briefly the Child Health and Education Mapping Tool, which is available on the Alliance's website. This is a great national GIS data set. It pulls in various surveys and indicators and allows you to visually map them. You're seeing Colorado here and various states, and you can sort of map different colors overlaying one another to see where particular indicators are sort of lining up. You can place dots to indicate the availability of certain resources. So a great tool to understand a state or county landscape. So another quick poll: what surveillance tools are you or your school using or have you used to identify the needs of children and youth? And I see in the chat a mention of the Search Institute's community surveys. I am familiar with their 40 developmental assets survey. There is a cost associated with it, I believe, and we tried to include those that were free of charge, but there are lots of great surveys out there that for you to use in your locality. And many of these do have racial and ethnic breakdowns. All right, and do we have some results?
So here we go. So for this poll, it looks like, again, the majority indicate that the participants say they don't use surveillance data or don't know. So it's about 28 to 31%. Of those who do use surveillance data, 17% use Kids Count, 10% use the RWJ funded county health rankings and roadmaps, and 17% use the YRBS. So those are some of the top ones.
Thank you, Olga. So after assessment, what comes next? This data can be used to leverage coalition building or coalescing around some priority areas and areas of shared interest. This can be used in your needs assessment processes to identify the gaps as well as the assets in your school and community, which can drive conversations around resource allocation. This can assist with care coordination and partnership development towards intervention development or referrals, your intervention and treatment planning for individual students, and the development of policy at the school level, local level, or state level. So I've seen that the brief 2 is already in the chat. That came out early this year, and this provides information on all of the screening and surveillance considerations with examples of each and the guiding questions to get you started. And now finally, as you get this data back, you've done your assessment, you have a glimpse into the lives of children in your community. How do you begin to address the myriad of issues facing children? How do you begin to support children who really have some complex needs? So we propose the use of a multi-tiered system of supports, or MTSS framework, which is a 3-tiered framework rooted in both a public health model and a school-based response to intervention instructional model, in which interventions are layered to deliver supports that are matched to the needs of students. And we see this framework as being very applicable to addressing social influencers, and that this can facilitate the delivery to students, again, based on their need. So this is how we have operationalized the tiers for the use of an MTSS to address social influencers. So that first is that universal level at the bottom, so promoting health and preventing adverse outcomes among all children in the student population. Tier 2 is preventing risk factors or early onset of problems for a targeted group of students thought or assessed to have more intense needs. And your tier 3 is individual student interventions that can address more serious concerns. So very familiar to you all who are working in school behavioral health, public health, a very similar framing that we've been able to translate. In addition to the tiers, we really believe that the principles of MTSS work well here also. So data-driven decision-making, effective teaming, progress monitoring, all of those come into play when selecting and implementing interventions. So just generally, what do these tiers look like? Tier 1, again, your universal health programs. These can be prevention programs, awareness weeks. This can include your health communications and resource dissemination through social media, newsletters home, flyers, emails, school community partnerships that provide services for all students, health and wellness events, fairs and expos, professional development for all staff, and school or district policies that advance equity. So again, those that are benefiting all children. And then at tier 2, we have the broad activities to include targeted screening, referral and follow-up activities when students screen at a particular risk level, small groups or support groups for students coping with particular challenges, support groups for at-risk families, and trainings and workshops that aim to support those that need additional knowledge or skill building. And tier 3 will provide more of the individualized social influencer support, like the individual screening, case management, care coordination, and more of that individual group or family counseling. So in brief 3, which will be shared in the chat, we have identified some of the more prevalent social influencers. We've articulated their health impact and provided intervention examples at each of the 3 tiers. So for example, in the case of unsafe housing, universally, you may disseminate information and host meetings in collaboration with your local health department to do education around lead exposure. At tier 2, for those households and students who might be at a risk level or require additional support, you can conduct virtual or in-person home visits. You may also refer students to the school-based health center for annual well check visits to conduct lead screenings as appropriate. And a tier 3 example is to refer families to local housing authorities to resolve certain exposures and assist in getting more safe and stable housing. There is also an example of food insecurity. Tier 1 is through offering universal school meals like breakfast, lunch, summer meals, evening meals we've even seen. Tier 2 can be working with partners and providers to do school-based food pantries and holiday food drives for those children who may experience occasional food insecurity. And for those with more persistent food insecurity, to refer families to the local SNAP office. Here's an example from Washington, D.C. We work very closely with a community-based organization called Mary Center that has a school-based mental health program. And so in addition to providing comprehensive school mental health services, you can see that they are also doing a number of activities that get at the social determinants of health, such as providing broad information on social services available and making those available at venues and forums that parents are attending, providing cash assistance and needed technology, having workshops for immigrant students and their families, and doing some linkage to wraparound services in the community and connection to COVID-19 services. So just one great example of the use of an MTSS for the social influencers. And so we are pleased to present our latest brief, the third in the series of 3, which provides an overview of the use of MTSS for these interventions with the rich examples at each tier, which we hope inspire work in your own schools. And so we believe that school-based health centers and comprehensive school mental health systems are great entry points to begin to do some of this work around advancing this concept, assessment, and interventions, but there is also such a role for leaders. Those at the local level and school level can focus on policies and practices that impact their school community, thinking through partnerships, and connecting with others in the community who can fill gaps in needed services. And at the state level, leaders can develop policies and monitor programs to roll this out statewide, focus on the collection and monitoring of data, thinking about equitable distribution of resources, and offering training and technical assistance on potential interventions. And so this is a new concept, but one that we will continue to advance. So stay tuned. We will continue to promote this through our series of briefs and through other forums. We look forward to developing new resources that can assist with planning, implementation, and monitoring of these strategies, as well as collecting best practices and examples to share with the field. There are very few examples other than some anecdotes that we have, and so we'd love to have case examples. So please put your name and email in the chat if you have an example of what your school and community is doing to address the social influencers. So we just want to thank you on behalf of the School-Based Health Alliance, the National Center for School Mental Health, and the Center for Health and Healthcare in Schools. Thank you for joining us today. Thank you for your participation in the polls and in the chat and Q&A. We look forward to connecting with you all and hearing about the great work that you have done. Thank you so much for joining. Have a good one.
Thank you, everyone.